Well, here we are at another episode, Renee. How are you doing?
Hey, I'm doing great. How are you?
Well, it's early March and something happened to me early March.
Uh-oh.
I passed a milestone birthday, Renee, and I'm not willing to talk about it yet.
Was it a big O birthday?
It was an O birthday, and so we're not talking
Uh-oh.
about it. Yeah, uh-oh, that's the one. So,
Uh-oh. And so you're not talking about it.
nope.
Are you celebrating? Are you celebrating this big O event, or are you just pretending it didn't happen?
I'm heading to a beach for spring break.
Oh.
That's the consolation prize when you have an uh-oh birthday. So,
So you go act as if you're still in college.
right, exactly.
I got it. Okay. So you're going somewhere warm for spring break to celebrate an uh-oh birthday. I got it.
That's
That sounds
correct.
like
So,
fun.
all right, so we can move on from there because that's really just left speechless.
Because you're just depressed. I get it. All right.
Mhm.
Well, today we're going to talk about the big picture of mental health system. And before we get started, I thought maybe you and I should just remind our listeners kind of why you and I talk about this and why are we, really versed in this topic. And I guess I'll go first, but for those that are listening that may have forgotten, I've helped design the mental health system in our state of Iowa because as a legislator, I knew it didn't work and I had foster kids in my home and we just could not get the services we needed and it was just a big old mess. And so when I was recruited to run for office way back when, that's why I ran for office. I didn't actually ever want to be a politician. So I was like, going to go fix it. And I wanted to really work on the children's system. But at the time, the adult system was so broken, I was told quickly that I had to fix the adult system first before a kid's system could even be attempted. So we started working on that and did that a long time ago. And the goal way back when for me was that people should have access to care, the same levels of care, no matter where they lived in Iowa. And so from then forward, now my life's work is really about that still and finding those groups and populations and areas of our state who still don't get the services that everybody else does. So, Jason, I know you too have a background in behavioral health. What's your kind of story and how'd you get here?
Well, ironically, I was on the provider side of things. So I managed mental health clinics, substance abuse treatment facilities, and I'd be at those provider association meetings complaining about what those legislators were doing over at the Capitol because they had no idea how it affected and impacted providers. And we'd always talk about this Schulte, who thought
Yeah,
she knew everything about the mental health system and didn't understand addiction at all. And so we'd sit around and complain and try to keep everything the same. And so, for those years, I learned a lot, right, about systems and legislation. And I think that's probably the first time we met was way
yeah,
back in the day. Would go into those committee meetings first thing in the morning at the Capitol, hearing
yeah,
about what the system was going to do. But, I think part of my background is how do we align those accreditation standards, both national
right.
accreditation with what services we provide? How do we integrate psychiatry and do co-occurring work, right? Before
Mhm.
co-occurring systems were in place, it was up to each provider to create their internal systems that actually provided holistic care for patients. And we served a lot of kids and teenagers and adolescents, family work. And so I managed a lot of federal grants where we bring in evidence-based practices. So kind of, my background is unique in that we actually provided some of that care decades before kind of became the hot topic to talk about just because we knew that was the right thing to be doing.
Right. You're one of the, what is it, hundreds of people I owe an apology to for those 7:30 a.m. meetings at the Capitol.
Yes. How many mornings of my life I lost having to drive to the Capitol. I know I'm still bitter about that maybe.
I
So
know. I Now that I don't do that anymore, I just cannot fathom the fact that I was there by 7:30 in the morning making people show up. But what was fun about it, as we started getting movement and as we started getting momentum, more and more and more people showed up. And I don't know if you remember this, but there was a particular senator I won't name over in the Senate at the time and got really angry because more people would show up at my meetings than not his. And I always thought that was super funny because that wasn't really a competition in my mind. It was just we got crap we got to get done over here. So yeah, it was just really funny to me. So yeah, I know you bring in the behavioral health side and the levels of care and ASAM and locus and all the things that have always been more structured, to be fair, on the addiction side than mental health ever has been. To be fair, you guys had levels of care defined and things defined where mental health, goodness, as we've talked before about when is a bed, boy, talk about when a service was a service. And when we first started down this road, all people called a whole lot of things, and they just weren't defined well as to what the service actually was, or what we were trying to accomplish in the service. And then of course then we had what we called a ton of legacy services, things that had absolutely no evidence base that it worked at all, but we just done it for tons of years, and people would get really, as we moved forward in redesign, really bent that we were trying to get rid of some of those things, even though they actually didn't really help people. And so I know both of us are thinking about all of that. So today what we're going to try to do and move forward with a series here is talk about what should this look like? And we're going to talk about it from the perspective of mental health and behavioral health together, because that's what the service and the system really should be, is co-occurring, multi-occurring, able to serve all people and wherever they go for service. That's that no wrong door approach that we always talk about. We're going to talk about it that way, but then, as you know, we're going to be more than happy to point out the gaps and where things fall short, because we deal with that all the time. So Jason, where do you think we should start with this conversation?
Well, I think a great place to start would be the updated fourth edition of the ASAM placement criteria. That just came out very recently. I believe December, I got my first copy. I pre-ordered my ASAM books. I was so excited that this was coming out. And I know that's really nerdy, right? Like who waits and is excited for that? But I think, ASAM, for addiction treatment and co-occurring addiction treatment, let's be honest, has always been one of the best roadmaps to help us to understand how do people transition from each level of care, right? Seamlessly transitioning to higher levels of care and lower levels of care. We've really struggled with mental health conditions to articulate it in the same way that ASAM has been doing it for a number of years.
That's right.
Now, the good, the bad, and the ugly is, right, that the new ASAM criteria cleans up a lot of things, right? This fourth edition cleans up some of those things that were left hanging. That how do you know if it's a hospital level or just a residential treatment community provider, right? And so the new designations in ASAM 4 clean that all up. The difficulty is it's going to be years before it's implemented, right? Managed care companies have to adopt it. Our state legislation, right, rules and code is actually written in ASAM 3. But I really want people to leave here thinking about, if you want to learn more, you can go to the show notes and we'll have some data we'll share with you here in a little bit. But to really think about, where do you go to find those continuums of care? How do you look that up, right? And so ASAM's a standard. We also can't have this conversation without talking about the locus, right? That's a dimensional rating system, right, that has 6 dimensions or 6 evaluative parameters that we look like. And so that's been largely used, and there's been lots of conversation on and off over the years about using the locus in Iowa. It's used sometimes, not always. I think that's been a real struggle as well. Those are the two biggest ones I think that we're going to focus around as we have this discussion today.
And on the mental health side, like I said, I helped write the law back in the day, and then got to write all the rules after that as a consultant, and then worked in the lobby as things have changed through the years. But mental health is not as structured as the addiction side was. And I know that was one of the biggest beefs about addiction in the first place, about you guys having anything to do with the redesign, is because like you had some structure and you already had a system, and you had things where it's like mental health was all over the place. So it looks like it was taking you guys out of what you guys were really pretty good at and messing it up, throwing it into mental health. And as we know, we can't divide people into those clean cut diagnoses or clean cut issues. And I rarely see people working now with people that are incarcerated. Almost, I'd say it's probably 90% have a co-occurring issue with mental health and substance. We see sometimes real clean cut, just substance issues, but even then, oftentimes they'll end up with additional challenges on the mood side because of the drug use. And so even if it was 100% caused by drug use, you'll still see some mental health effects. And it's really, really uncommon to see them just separated, where it's a clean cut, just this or just that. And so to try to bifurcate people into this camp or that camp, and you have to go to that camp first to get this service first as priority before you get help with this other camp, and having to have more than one place to go, more than one assessment, more than one treatment plan is just a mess. And on the incarceration side, that's a thing today. That's absolutely a thing today. So it drives me crazy. But if we make recommendations for people on parole to get a substance abuse evaluation or a mental health evaluation in the system, it's two different people.
We might want to celebrate, Renee, because you realize it was only as recent as the 1980s that there were standalone alcohol treatment facilities in the state of Iowa. And if you were an alcoholic, you would have to go to a separate door and a separate treatment provider. than if you were using cocaine, right? Because
Oh,
they wouldn't treat alcoholics the same as they treat addicts, right? And so I had
oh,
mentors in the state who would tell me about don't forget where we've been, right? Because it wasn't that many years ago that there were separate licensing criteria. There was separate
wow.
there was an entirely separate system, right? And so
Right.
here we are now, 30 or 40 years later, saying, now wait a minute, what happened then? And that was a huge change at the time when
Wow.
addiction became under one umbrella. And so here we are putting the whole person back together. But look at our past. We've had these silos before. We've been trying to dismantle silos for literally decades and decades, and it's
True.
just been such a challenge.
Right. So today, as we talk about this, what we're going to try to do is sort of do an overview of what a system looks like, all the way from the lowest levels of care to the highest levels of care, and then kind of the more long-term level of care. And so for the discussion, we're thinking to start it broken down into kind of 4 parts to start the discussion, where you kind of have outpatient services, and then you move into crisis services. Now, crisis are a lot of different things, and so that's going to be more broken down as we go into this series. But then talking about acute level services, when you have an immediate urgent type crisis, and then residential services. And the reason we're going to try to break it down into all those levels is a good system has all of that. And there's not gaps where people fall between them. It's actually where people get warm handoffs between the different levels of care. And your co-occurring, multi-occurring treatment where people can get treated for all the different things that they need at all those levels of care. Now, we're going to be really honest with you as we start. There are things on paper, and there's going to be things in policy and things written in ASAM book where it looks like that should be easy peasy, all drawn out and working the way it should be. But we all know that when we get into this discussion, it's not so much like that. So Jason, talk to us some about the criteria that you see in ASAM and some of that data focus, because let's start with ASAM because it is going to be stronger as far as what that system's supposed to look like.
Yeah, absolutely. And so when I talk about ASAM, I'm going to be referencing more ASAM 4. And so some of you are going to be like, well, that's not what that is. He doesn't know what he's talking about. Well, so, we're kind of in that gray area, right? So I'm kind of bridging us to where we should be and where we need to be going. And, really, as Renee talks about that transition to levels of care in ASAM, we're really talking about transitioning from outpatient to intensive outpatient, right? When we need more intensive services than just what outpatient can do. So those, 3 to 4 days a week, groups, all the stuff that happens. And then thinking about recovery residences, right? They're kind of an in-between spot between residential treatment and where we are now outpatient, right? And so thinking about, well, how does that fit in? And I really like how that fits in really nicely in the new ASAM criteria. And then at the very top of that triangle, I like to think of it as a triangle, is inpatient level of care, right? And that's acute care, right? But there's a whole lot of other things we can build in underneath before we get to acute care. And oftentimes that's where we miss the boat when we think about a healthy behavioral health or addiction treatment system is we forget about all those levels of care that aren't acute. So everything from residential to subacute, all those different levels of care, right? And those are different than recovery residences, which is a place to live, which is also very important. And so, it's time that we really start to unpeel that onion so we can clearly articulate all of those things and differentiate them appropriately.
Right. And some of the places that we've worked, to your point, will have outpatient, which is just like a regular appointment with your therapist, and inpatient, where you're in an emergency department, maybe not even in an inpatient unit where you get multiple days, but maybe it's just an emergency department only, and that's it. That is absolutely it for everything. And there's no levels of care in between. And that's just a disaster. It's a revolving door. And people that are in the middle that wouldn't need to be sitting in an emergency department just can't get enough help at the higher level that they need it to be able to stay in a community. And so when we're talking about this today, thinking about it, whether you're thinking about it on the addiction side or on the mental health side, as they should be one side, as we keep talking about, but so far as we've been developing these systems, are two. And so you're going to see where some of these things now start linking together a little bit different. So thinking about the mental health system, and our show notes are going to have a lot of different links for you to be able to look at what it looks like. I am going to reference the Iowa mental health system just simply because I am so familiar with that, but it is very similar to other systems you'll see in policy. around the country. And we all know what's in policy versus what's in practice doesn't always line up. We know that. But in policy, generally, there is a pretty good roadmap now for mental health. It is not as designed as ASAM. It's not where you have the numbering system and the levels of care as much, but it is more designed. And so you start thinking about outpatient. And on the mental health side, we've had outpatient. We've also had intensive outpatient, which is that more 3 to 5 days a week type work. But we have something that's called an ACT team, which is an assertive community treatment team, which can be something that you can use to wrap around people living in their communities. And that's considered outpatient because you're not going to a facility for services. And so there are different things at that outpatient level. We'll dive into that a lot deeper in the next conversation on our next podcast. But after you get past outpatient, then you start talking about what has to happen for crisis services. And this is going to be probably a multi-piece part of our series because crisis services have really grown. That's been a piece that's been added into the system, and it keeps changing and growing. And there's some federal initiatives making that really a lot better. And then once you get past crisis system, you're supposed to have a place to go. And that place can go 2 ways. It can go if you need to be in a hospital setting for acute type residential or acute, where you're there for just a short period of time, but at that highest level because you're a harm to yourself or someone else. And then there's a residential component to that that's much more, that's going to be longer term. And you're going to hear from advocates in our community and our state that the system does not include even longer term residential like it should, that more transitional housing or what they call housing that heals. And our system still doesn't really have those pieces in it. And so you'll still see some gaps, even though now there is a system from all the way from outpatient all the way up, that some people think that there needs to be longer types of places. And these in the history of our state used to be like our mental health institutions where people would go and stay for a really long time. Again, not evidence-based, not necessarily best care. And so now there seems to be a conversation where maybe we're heading back that way. And Jason, didn't you talk to me about that, where Congress is talking about now looking at mental health institutes and things like that, that maybe we swung too far to letting people out when they really needed more assistance? Wasn't that a conversation you and I just had?
Yeah, it was. It's actually on the table right now in an active discussion congressionally right now is was it a mistake? Is there something we should be doing? I think part of that has to do with too many people in jails, right? Like, is there a more appropriate level of care for individuals who need more than what maybe our community providers can provide? And so, limiting, the size of facilities, communities, was originally around deinstitutionalization and getting people reintegrated back into communities. Well, there's some folks we're now finding that isn't working well, and I know anecdotally, we both have a friend whose son who is in a community-based facility who was in an institution and did better, thrived in the institution, and is really struggling in a community. And this is really hard to treat mental illness, and so clearly an exception. But, it's a good example that maybe one size doesn't fit all. And maybe there was some positives to some of those things. We know there's horrible things that also happen in institutions, but finding that balance of what do we need and how can we best help people be their best in the midst of their illness or their disease. And so I think that it's a good conversation to have. It's kind of ironic that advocates are now saying, well, wait a minute, maybe we need to go back here, and there's ways that we can do that. And right now, as Iowa's, literally emptying out all of their institutions, I don't know if we're adequately planning for then the supports we're going to need moving forward. And so as we think about what should a mental health system look like, if we don't have all of those levels of care in a mental health system, then how can communities grapple with individuals who are moving out of institutions and into communities?
Right. I know I'm going to be jumping ahead here, but I know the answer to Iowa is it's not. And the way I know it's not is when we did complex needs, where we were adding some additional types of services to this spectrum of care back, probably, was it 4 or 5 years ago now? One of those things was what was called an intense residential service home, or an IRSH home, they ended up calling it. And the idea at the time was there was about 120 people that they could identify that needed longer term place to stay. And they were going to put them in more of like group homes, but small ones, like 3 to 4 people, or individualized apartments or whatever. And that just has not been developed in our state, while the institutions are still closing down beds. So the issue is that providers could not figure out how to do it in a way to staff it, in a way to fund it, in a way to make it sustainable. And so that has been an ongoing project that if it was truly up and ready to go, now there are some been developed in our state, but not the number that they thought. And so as some of these beds are closing, if that community piece doesn't get picked up quicker and doesn't get established sooner, I can guarantee there's no place for them to go. And I don't know if you've seen these, some of the data, Jason, but there's pictures out there about how the beds, as they've decreased in these state institutions, the number of people in jail just increased comparably the opposite direction, and the numbers are basically crisscrossed. So as the beds went down, the beds in jails went up. And to your point, people are still in residential. They just moved from one HHS system into correctional system. And so now you've got lots of people, not just in our state, in all kinds of states at the prison level that have lots of mental health and substance use issues, and then in the local jails. And so I've seen a bill this legislative session that is trying to get HHS to have to pay people who have certain types of offenses who can't be removed from jail so many dollars a day to have to fund the jails for having to keep them. Things like that, because it's like this money is being moved from department to department as far as who's responsible for caring for folks. And it gets expensive, because I can tell you, if you're incarcerated and you need anything healthcare wise, you're paying it out of pocket. You cannot access Medicaid. You cannot access Medicare. You cannot access SSI incarcerated. So every piece of equipment, everything that you need incarcerated is general fund 100% of the time. Whereas when they were in mental health side of things and in more institutions, some of that was limited due to some congressional acts, but they had more options for other types of funding to get people help. And so I'm really glad Congress has taken a look at this, because yes, you're right, really bad things happened and they become sort of dumping grounds for people who shouldn't have been there. But there are people who just need help, and we've got them all in the wrong places. And so trying to figure out what's the better system is really important. So Jason, I know some of the gaps that you still see when you're looking at ASAM 4, can you see in Iowa some of the places that you think that we're going to have some need to change and to grow as you see what the vision is moving forward federally in that space? Like, where are some areas that Iowa's going to need to figure out how to do that better? Is that a gap?
Yeah, I think it's important as we look at this, we look at it through the lens of certified community behavioral health clinics, or CCBHCs, right? And so, we think about the array of services that are required under a CCBHC and how Iowa has kind of rapidly tried to embrace it, but kind of in a scattershot way that doesn't really have any consistency and has just kind of supported it regionally. And so I think part of the challenge we have is finding consistency across the state in order to fill those gaps. And so, when you think about gaps, I think about, the ones that are top of mind would be, access to mobile crisis, access to some of those basic core services. And when I think about substance use treatment, I think about access to medications, and being able to have that consistently, even in rural areas, just because it's so much harder to manage those types of things in rural areas. And then as you talked about crisis residential, or the IRSH homes, right? Like there simply there aren't enough beds or in the right locations for some of those services to occur and actually be then responsive to local communities.
Right. I know in our conversation, today, maybe people thinking there's no hope that this is terrible and it's not going to get better. But actually, that's not the way I would like people to leave our conversation today, because a lot of the federal policy that's coming down is more multi-occurring and co-occurring focused. So your ASAM criteria is 100% that way. But the use of 988, the crisis number, for those of you that don't remember the crisis number, it's not just a call for a suicide hotline, but for crisis, but it has a three-legged stool. And the three-legged stool was the phone call, of course, getting picked up within that 30 seconds. The second part, though, is a mobile response, which is really important. And then the third leg was a place to go. And that's exactly some of these conversations about where those gaps and the shortcomings are. So that's a second initiative. And then the one with the CCBHCs that Jason just mentioned, that Certified Community Behavioral Health Center, that for the first time is looking at this from multi-occurring dual diagnosis. We had community-based mental health centers, but they were siloed and they were not connected to behavioral health. But this new wave that they're working on federally also now combines the two. So we're finally getting from the federal government a real push to combine people back as one person and not separating addiction out, not separating it out. And then I think the fourth thing, if you're in the state of Iowa, that should be of hope is that the reorganization by the state that the governor did that started July 1st of 2023, it was a massive reorg and it seemed like a whole lot of difficulty, and there's a whole lot more to come. But generally, it housed now for the very first time public health in human services, and public health is where all the dollars went for substance use and addictions. And HHS is where all the monies had gone for mental health. And so not even the monies were in the same place. And so now finally the structure is correct to be able to treat people. They put aging in the same department for finally. So, there used to be these cutoffs, like if you were a kid, as soon as you turned 19, you got flipped to something new. And as soon as you turned 65, you got flipped to something else. And instead of treating people like these compartmentalized pieces, now the system is actually on policy able to look at a whole person. And so that doesn't feel like that today. But for me, Jason, that's one of the biggest things that I see is that there's policy now that actually is helping us move forward. But on the front of practice, Jason, what do you see? Do you see us all working together as a whole person, or what else do you see out there?
I think we have a ways to go, and I think some people are like, well, what do you mean? How can you not treat the whole person? And I think you did a nice job of explaining it. Like, there's still two separate licensing bodies, right?
Yes.
If you're a substance use treatment provider or you're licensed accredited under Chapter 24 as a mental health provider. I mean, there's some very real structural divides that keep us from treating people in a co-occurring, competent manner. And I'll tell you, as recently as last fall, I sat in a mental health clinic's office and the CEO said to me, yeah, we have an agreement since 1983 that if you have a substance use disorder, we don't treat you here within our walls. We send you across town. Right. I mean, and so those things still happen. And my head explodes when I hear that, because I'm like, this isn't co-occurring competent. This isn't how we treat people. There's nothing here that would be anywhere related to best practice that I've learned about since I was in grad school. And so how do we still promote this as being a thing? And so I think we still have that hurdle to get over. And so, yes, our systems have to align so that then we can help to put people kind of in more of an uncomfortable spot where they have to move to where we should be in 2023 when it comes to treating people with co-occurring substance use and mental health conditions.
Yeah, I'm going to put my plug in for that too, for licensure. So, I'm a licensed mental health clinician, and as trained in the DSM-5, I can do everything from mental health, substance use, and everything in between. But there's this group out there that says, oh, and by the way, you have to have ASAM and you have to do this and you have to do that, because if you can't do this and that, then you can't actually give people their assessments. That's not actually how you're trained. And so there's still, like you said, there's this clash of licensure, and you have to have this licensure or this credential or whatever to be able to do assessments. And all that does is put people in this cycle of trying to get help. And so, like I said, if you release somebody out of prison into parole and it says mental health and substance abuse, that's automatically in their minds going to two different people for two different evaluations who probably have two different treatment plans. And you've got people in a space where they're already vulnerable and having a hard time, especially if you think about having a felony conviction, which is really tough to try to get back into the workforce or to find jobs, find work. And then they've got this competing treatment level stuff going on where they're supposed to be getting supports to be re-entered into the community. And that becomes such a barrier that they can get revoked back to prison because they couldn't get their treatment stuff done. And that's a treatment system problem. We're making it too hard for people who need support and help to be able to be healthy moving into the community. We're just making too many barriers. And so if they've got those long time wait lists, which we'll talk more about next time on our podcast, or different barriers coming up, it just makes it impossible. And so then they get revoked for oftentimes because they've done many more illegal things in the meantime, because maybe they didn't keep their medications or who knows what, but whatever's going on, they get revoked. And then you can see that, hey, they never got the substance abuse eval. They never got the treatment they were supposed to get. They never got connected to their sponsor, blah, 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 blah. And so what kind of a service are we doing for those folks, right? It doesn't help recidivism. It doesn't help keeping people in the community, in the workforce, and it's just a mess. And so Jason and I can talk about this forever, the number of pieces that of this system just are not doing what they're supposed to be doing. So the hope is on paper and in policy, people are really starting to think about the fact that we're a whole person. But in practice, boy, do we have a long way to go. Jason, do you have any other thoughts on that?
I don't. I can't wait to the next episode to learn more.
Well, the next episode, I think, aren't we going to be diving into outpatient and thinking about like how that lowest level of care is supposed to work? I'm sure there's going to be 1,000 things we can talk about there that's not quite right. But for now, let's just settle in and think about what we're going to do for our recovering politician self-care tip of the week. So for me, it's setting a boundary, and not for other people, but for myself, about getting a regular bedtime and a wake-up time. I started tracking my sleep a little bit better and have an actual fitness tracker that helps me with that. And it's amazing to me the difference what happens if you actually get a decent night's sleep. And research will show you that most adults need 7 or 8 hours of sleep. It doesn't matter if you've heard those stories about those crazy people out there that get 3-4 hours a night. That's not the norm by any stretch, because to be able to actually get the deep sleep you need for rejuvenation and restoration, you actually have to be in bed a while. You don't get all the deep sleep. You only have like maybe, it's 15 to 20% of your night could be deep sleep, which is the restoration. The rest of it's a lot of other types of sleep that do other things. And so you've got to be able to be asleep for a while for you to get the benefits. And many adults just fall super short of that goal. So the one way that I really improved this for myself was just scheduling kind of a bedtime. And I know that sounds ridiculous, but some of the best things I learned as a kid are things I kind of need as a grown-up. I kind of need a bedtime and I kind of need naps. And I'm not going to be sad about that, because the more I can think about being on time with how I sleep, the better off I know I am. And Jason, I know you've been working on sleep too. So what do you think about that particular type of self-care?
I couldn't agree more. I know that I started that pre-pandemic, right? 2020. I really recognized how important sleep is and what an impact sleep has on mood, my ability to get things done, productivity, you name it. Sleep is everything. And so, I just can't undervalue enough when I talk to people and people tell me how exhausted they are.
Yeah.
I'm just like, man, you got to take care of yourself, right? That's the easiest. And it's hard sometimes. Get it? I shouldn't say easiest, but you can have the most impact, right? It's not going out and running a marathon. It's not doing all these other things, right? Just start with those things that you can put some parameters around, and start with a bedtime. Start with, a routine, and make it be about sleep.
That's right. Well, today, everybody, we tried to start laying out like the 30,000-foot view of kind of like, what does a mental health system look like? And that includes mental health and substance use and everything. What could it be? What could that system look like? What is the goal? And thinking about how should that look as we move forward? And so Jason and I have worked in this field for a long time. We know the way the system is designed and structured on paper and in policy. And we also know that it doesn't always work that way in practice. And so we're going to be diving in this next coming series, not been sure exactly how many podcasts it's going to be yet, but we're going to be looking at each level of care and then doing some breakouts on some specific special levels of care that I think people need to know more about. Because as we start having this conversation, you're going to see that there are certain things that are available to people that people just don't know that exists and would be really beneficial for more people to know about. So we're going to dive into that as we move forward. So we'll see you again next week. Have a great day, everybody.